Adult orthodontics is not just about straightening teeth. It's about restoring equilibrium in a system that's already lived through decades of function, adaptation, and sometimes trauma. When we treat an adult, we're not starting from a clean slate. We're entering a mouth that's been through restorations, extractions, bone loss, perhaps TMJ adaptations, and muscular compensation. That's why adult orthodontics can't be practiced in isolation. It's interdisciplinary by necessity. It requires an orthodontist who can think like a periodontist, communicate like a prosthodontist, and plan like a surgeon, because all three systems meet at the same patient. This masterclass will take you step by step through that world. The logic, the biomechanics, the clinical sequencing, and the human factors that make adult therapy a discipline of precision and respect. 1. The reorientation of orthodontic thinking. If you look at the history of orthodontics, for most of the 20th century, the field revolved around children and teenagers. Braces were considered part of adolescence, something you did before your jaw stopped growing. But beginning in the 1970s, a quiet revolution began. Researchers like Rydell and Doherty started to argue that orthodontics is a total discipline, that the same biomechanical principles apply whether the patient is 14 or 45. Their prediction was bold at the time, but they were right. By the early 2000s, the number of adult orthodontic patients in the United States had increased by almost 800%. The reasons were clear: improved techniques, lighter forces, better bonding systems, and, most importantly, patients who understood the connection between dental health, aesthetics, and overall well-being. Today, adult patients make up more than 1/5 of orthodontic caseloads, and unlike adolescents, their motivation is powerful. They seek restoration, confidence, and function, not just appearance. 2. Goals of adult interdisciplinary therapy. When we plan an adult case, we must accept a simple truth: perfection is not the goal. Balance is. In 1972, Andrews gave us the 6 keys to normal occlusion. That blueprint remains the gold standard. But in adults, that standard often becomes biologically unrealistic. Imagine a 48-year-old patient missing molars, with periodontal bone loss and a tilted occlusal plane. Forcing that case into an adolescent Class 1 ideal can destroy what's left of their periodontal support. Adult orthodontics is the art of compromise: intelligent, informed, and functional compromise. Instead of asking, "How can I make this textbook perfect?" ask, "What is achievable without risking tissue health? What provides facial harmony and occlusal stability? And, most importantly, what does the patient truly value?" For adolescents, we chase growth potential and symmetry. For adults, we protect what remains, restore function, and respect the biology that's already aged. The key takeaway: efficiency, predictability, and collaboration outrank textbook alignment. Individualized treatment objectives. Adult treatment objectives must integrate every specialty's perspective. They're not just orthodontic targets, they're interdisciplinary blueprints for rehabilitation. Let's unpack the 12 major objectives of adult orthodontic therapy, each one supported by decades of clinical evidence and illustrated through case studies. 1. Parallelism of abutments. When abutments aren't parallel, prosthetic work becomes a nightmare. You'll need aggressive preparation, risk pulp exposure, and compromised crown retention. Orthodontic uprighting before prosthetic preparation allows natural long-axis alignment, minimizes cutting, and ensures even force distribution. Think of it like aligning pillars before placing a bridge. The stability of the restoration depends on it. Clinical example. In one case, uprighting the maxillary posterior segment before full arch splinting reduced the risk of cement washout and improved bone response long-term. 2. Favorable tooth distribution. We often inherit patients with missing teeth and uneven spacing. The orthodontist's role is to redistribute teeth so prosthetics can be logically designed. If abutments are too close, pontics become narrow and unaesthetic. If spacing is uneven, occlusal balance is lost. A simple distal movement of a premolar can create a symmetrical foundation for a 4-unit bridge, avoiding removable partial dentures altogether. 3. Redistribution of occlusal forces. Bone loss cases need forces redirected vertically, not laterally. In patients with 60–70% bone loss, the long axis of each root must align with the direction of occlusal load. You can't stop bone loss entirely, but you can stop the cause of trauma by re-angulating teeth. The result? Function is maintained, and the vertical dimension is preserved without surgery. 4. Proper embrasure and root position. Adults don't lose bone evenly. Malaligned roots compress interproximal bone and block embrasures, making hygiene almost impossible. Orthodontic realignment recreates natural spacing for floss and restorations, improving long-term periodontal health. Teaching analogy: it's like rearranging books on a shelf. If the spacing is wrong, dust and debris accumulate where you can't reach. 5. Establishing the occlusal plane and vertical dimension. In mutilated dentitions, the vertical dimension often collapses. Using a Holly bite plane allows us to re-establish centric relation at a functional height. Patients can speak normally, muscles deprogram, and bilateral activity returns. This is especially critical in collapsed bites, where posterior interferences have led to TMJ strain and muscle fatigue. 6. Occlusal landmark relationships. The transverse dimension is the most fragile. If you're planning restorative work, posterior teeth must meet in precise buccolingual relationships, maxillary buccal cusps over mandibular fossae. Correcting these planes prevents long-term relapse and uneven loading. 7. Lip competence and support. Adults, especially women, are very aware of perioral aging. Excessive retraction or lack of incisor support deepens wrinkles and shortens the upper lip. Orthodontic retraction must maintain lip support and create passive closure, not strain. Sometimes, slight proclination of lower incisors is justified to preserve balance between function and aesthetics. 8. Crown-to-root ratio. In periodontally compromised cases, extrusive orthodontic movement can recover bone support. As the tooth erupts, the bone follows, effectively improving the clinical crown-to-root ratio. Combine this with regenerative procedures, and you can turn hopeless teeth into stable abutments. 9. Mucogingival and osseous correction. In adults, we don't level marginal ridges, we level the bone crest. Proper bracket positioning can realign gingival architecture without surgery. As teeth move to their biologically correct positions, mucogingival form improves naturally, reducing the need for grafting. 10. Self-maintenance of periodontal health. Once teeth are correctly positioned over their basal bone, patients can clean them more effectively. In early treatment, some adults need weekly periodontal scaling. But as inflammation resolves and embrasures reopen, maintenance intervals extend to months. Proper position is the best long-term therapy. 11. Aesthetic and functional integration. Aesthetic harmony follows functional correction. In open bite cases, when incisal disclusion and posterior support are restored, myofascial pain diminishes and facial harmony returns. You're not just aligning teeth, you're recalibrating an entire neuromuscular system. 12. Best outcome with least risk. Modern orthodontics offers us powerful yet conservative tools. Temporary anchorage devices, sectional mechanics, and micro-movements allow us to correct local problems without full arch intervention. The philosophy is simple: move as little as necessary, but as precisely as possible. 4. Diagnostic framework. Oriented approach diagnosis in adult orthodontics is more than identifying a malocclusion. It's the art of defining every system that influences the case. Traditional classifications, Class 1, Class 2, Class 3, tell you where the teeth are. They don't tell you why they are there or what biological limitations exist. Adult therapy demands a problem-oriented diagnostic framework, a method borrowed from medicine known as the POM-R, the problem-oriented medical record. We start by identifying problems system by system: skeletal, dental, periodontal, TMJ, aesthetic, and behavioral. Each problem becomes a separate entity with its own assessment and treatment plan. For example, you may have a skeletal Class 3 discrepancy requiring camouflage, periodontal bone loss around the molars, aesthetic disharmony due to lip protrusion, and parafunctional bruxism affecting occlusion. Treating these as one global Class 3 diagnosis ignores the complexity, but breaking them into distinct, solvable components brings clarity. This structured reasoning allows the orthodontist to act as the coordinator of a multidisciplinary team. It ensures that periodontists, prosthodontists, and surgeons are aligned under the same diagnostic hierarchy. Every accurate plan begins with data integrity. The quality of your diagnosis limits the quality of your result. 5. Skeletal differential diagnosis. Skeletal analysis in adults is a reality check. Growth is complete, compensation is mature. The question is not, can we grow it, but can we camouflage it, or must we cut it? We assess in 3 planes: sagittal, vertical, and transverse. The Bolton template system transforms the phyllometries from a table of numbers into a visual logic map. Overlaying a standard template on the patient's tracing lets both clinician and patient see the skeletal imbalance. For instance, a patient may have an apparently normal A and B stooges, but when you overlay the template, you'll see maxillary constriction of 6 mm, a transverse deficiency invisible in sagittal analysis. Transverse discrepancies above 7 mm almost always require surgical assistance, typically SARP, or surgically assisted rapid palatal expansion. Below 5 mm, we can manage orthodontically with slow expansion or torque compensation. Clinical example. A 34-year-old patient presented with anterior crossbite and asymmetric wear facets. Template analysis revealed a unilateral transverse deficiency of 5 mm. With asymmetric expansion and vertical control mechanics, we corrected crossbite and rebalanced occlusion without surgery. Key takeaway: never rely solely on A and B or widths. Adult cases hide asymmetries. Only 3-dimensional evaluation exposes the real skeletal truth. 6. Periodontal differential diagnosis. 80% of adults over 50 exhibit some form of periodontal attachment loss. For the orthodontist, that means the bone we depend on is thinner, more irregular, and less forgiving. You must diagnose the periodontium before you move a single tooth. The rule is absolute: never move teeth through active inflammation. Begin with full mouth probing, plaque indices, radiographic bone mapping, and microbial testing where possible. Determine whether the periodontium is stable and reduced, unstable and active, or regeneratively responsive after therapy. In reduced but stable bone, light orthodontic forces can actually improve architecture. Movement reestablishes proper root alignment and facilitates self-cleansing. But in active disease, movement accelerates attachment loss. That's a disaster you can prevent with early coordination. Risk factors. Key systemic and local risk factors include smoking and diabetes, systemic; thin gingival biotype and traumatic occlusion, local; poor plaque control, behavioral. The orthodontist's responsibility is to identify, document, and control these before activation. Analogy: think of the periodontium like a cracked foundation in a building. You can remodel the walls all you want, but unless the foundation is stabilized, the structure will fail. 7. Temporomandibular joint (TMJs) differential diagnosis. Diagnosis: temporomandibular disorders often coexist with malocclusions, but correlation doesn't equal causation. In adults, especially between 25 and 45 years old, we encounter a broad spectrum of joint symptoms: clicks, muscle pain, headaches, deviations, or simply fatigue. Diagnosis begins with 3 questions. 1. Why? Where is the pain? Joint, muscle, or both? 2. High. What's the pattern? Acute, chronic, or adaptive? 3. What triggered it? Trauma, parafunction, or occlusal interference? A careful history is more valuable than any MRI. Ask when symptoms started, what relieves them, and whether bruxism or emotional stress plays a role. Okuson's functional triangle reminds us: occlusion, joint, and muscle work as one system. Disturb one, and the other 2 compensate. Orthodontic movement alters occlusion, so we must anticipate how that shift will affect the joint. Clinical example: a 39-year-old female with posterior collapse and mild clicking. Through disarticulation with a bite plane, we restored posterior support before alignment. The clicking resolved spontaneously as condylar seating normalized, proof that conservative functional control often solves the symptom. 8. Clinical management and biomechanics. Now we enter the mechanical heart of adult therapy. Adult bone is denser, the periodontal ligament is narrower, cellular response is slower. The fundamental principle: light continuous force produces movement, heavy intermittent force produces damage. Disarticulation and biplane control. Disarticulation through a Hawley biplane or posterior buildups temporarily removes occlusal interference, allowing free tooth movement without traumatic contact. In deep bite adults, this prevents jamming of posterior teeth during leveling. Think of it as putting the occlusion in neutral gear. The engine runs, but nothing grinds. Selective grinding and occlusal adjustment. Before applying mechanics, equilibrate occlusion if needed. Minor enameloplasty or selective grinding removes interferences that would otherwise direct forces laterally. This preserves periodontal health and accelerates tooth movement because forces are aligned with the long axis. The process must be planned, never random. Always after study cast articulation. Modified mechanotherapy for adults full arch bonding from day one is unnecessary and risky. Instead, use staged or sectional bonding. Align posterior segments first to stabilize anchorage, then proceed anteriorly. This minimizes plaque retention, patient discomfort, and periodontal stress. Light nickel titanium wires for alignment, followed by rectangular stainless steel for control. Always checking periodontal response between stages. Avoid rapid torque or intrusive forces on reduced bone. If intrusion is needed, use mini implants or cantilever springs to offload stress. Clinical example. In a 52-year-old with 30% bone loss, controlled intrusion of lower incisors by 1.5 mm over 4 months using 10.15 g of force restored overbite without further bone loss. Anchorage control. Anchorage in adults must be absolute. Teeth alone can't always resist reciprocal forces. Temporary anchorage devices, TADs, provide predictable anchorage with minimal invasion. Use them for molar intrusion and mass retraction or space closure without reciprocal movement. Analogy. Think of TADs as scaffolding in architecture. They hold the structure while you rebuild the interior. For system optimization, visualize forces as vectors. The more you control the direction, the safer the biology. In adult cases, use differential moments to avoid root resorption. If a tooth has short roots, apply counter-moment mechanics or split movement into stages. Tip first, then torque. Periodontal protection. During mechanics, reevaluate every 6 to 8 weeks. Check pocket depths, mobility, and gingival inflammation before activating new wires. Remember, in adult therapy, biology dictates the schedule, not your appointment book. 9. Interdisciplinary coordination. Interdisciplinary treatment is a symphony. The orthodontist is the conductor, responsible for timing, communication, and harmony. Here's the recommended sequence for most adult rehabilitations. 1. Periodontal stabilization. Scaling, root planing, surgical correction if needed. 2. Orthodontic realignment. Establish bone-friendly tooth position. 3. Saw prosthetic or surgical reconstruction. Crowns, implants, or orthognathic correction. Every handoff must include current records, radiographs, models, and occlusal analysis. Clinical coordination example. A 55-year-old patient required crown lengthening on 13 and 14, orthodontic intrusion on 11, and implant at 24. The team scheduled treatment in alternating 6-week blocks. Periodontist first, orthodontist second, prosthodontist last. The result? A stable occlusion with ideal implant loading and aesthetic symmetry. Without sequencing, that same case would have failed through overload or relapse. In interdisciplinary therapy, communication equals control. No email, no file, no X-ray should go unshared. The moment communication stops, the plan fractures. 10. Risk management and long-term stability. Every adult case carries biological and legal risk. The patient's tissues are less adaptable, expectations are higher, and outcomes must last. Risk management begins with documentation, periodontal charts, radiographs, informed consent describing realistic limitations. Retention planning. Retention in adults is forever. Because remodeling slows with age, relapse potential remains high. Use fixed retainers bonded canine to canine where feasible, supplemented by removable night appliances. In periodontally reduced cases, design retainers that avoid excessive gingival contact and allow hygiene access. Functional equilibration. After orthodontic debonding, minor occlusal equilibration may be required to refine contacts and protect the joints. Remember, an adult patient has years of neuromuscular memory. The system needs gentle reprogramming. Maintenance phase. Establish a strict recall program, 1-month review to evaluate retention. 3-month hygiene check. 6-month radiographic review. Long-term success in adults depends on discipline, both yours and the patient's. Common sources of failure. Failures fall into 3 categories: biological, untreated inflammation or excessive force; mechanical, anchorage loss or wire fatigue, behavioral, poor hygiene, missed appointments, or bruxism relapse. Recognizing which one caused the setback allows targeted correction before permanent damage occurs. Professor's reflection: stability isn't achieved on the day you remove the braces. It's achieved when the teeth, the bone, the muscles, and the prosthetic plan coexist in equilibrium. That's why interdisciplinary therapy is not a treatment, it's a philosophy. It's how we honor biology, mechanics, and the human experience simultaneously. Conclusion. So, let's summarize. Adult orthodontic therapy succeeds when we diagnose holistically: skeletal, periodontal, TMJ, aesthetic, coordinate across specialties with transparency and timing, manage risk through documentation, retention, and follow-up. Every adult case is a collaboration between tissues, between clinicians, and between disciplines. In the end, we're not just moving teeth, we're rebuilding balance, one biologically respectful movement at a time.